spondylosis is the word which people use very commonly, but they
Yeah.
don't understand the meaning.
Yes.
In short, spondylosis means the aging process of the spine. Like if a person gets old, he will get the graying of hair, right?
Yes.
Sciatica, that is pain
Yes.
in the buttock, which spreads to the back of the thigh and
To
in the
the
calf.
lower
Yeah,
legs.
very severe
Yes.
pain while walking or
Yes.
climbing stairs,
Even
etc.
standing
also becomes
Yeah.
difficult.
Yeah.
If it progresses to spondylosis and the entire group of for first few steps, there won't be any symptoms.
Okay.
After few steps, let's say about 5 minutes or 10 minutes, the person will start getting heaviness in the lower limbs.
Okay.
Sometimes there is tingling, sometimes there is pain. Also, there is pain in the low back. And after some time, the person has to just stop or
Okay.
sit down and
Okay.
take rest. Otherwise, he cannot go ahead.
Hello and welcome to today's podcast. I'm Dr. Tushita, and today we have with us Dr. Jaidev Panchwagh, the world famous brain and spine surgeon. Sir, welcome back on today's show.
Nice to be here.
So, today we have some very interesting topics with you to be discussed, sir. I think these are few cases which you see very frequently. One of those are slip discs,
Yes.
endoscopic spine surgeries. So, let's start with something very basic, sir. What is a slip disc and how is it related to lumbar spondylosis?
Yeah, very interesting question, because you see, everyone has back pain sometime or other during lifetime.
Oh, yes.
It is a very common problem.
Yes.
And the entire process of spondylosis starts with changes in the discs. So what is a disc? What is intervertebral disc? See, nature has made our spine segmented into
Okay.
small segments. As you
Okay.
know, our spine has got multiple vertebrae
Yeah.
arranged one over the other. But
Yes.
in between those vertebrae, there is a structure, and
Okay.
that structure is called as a disc.
Acha.
Okay. And the disc is made up of two parts: the central soft part, which is jelly like,
Okay.
and the surrounding part which holds that jelly. So central part is called as nucleus pulposus, and the surrounding firm part is called as annulus fibrosus.
Acha.
Just imagine if our spine was not segmented. If you start walking or running, it would have broken
Yeah.
if it was just one stick.
Yeah.
So our spine is segmented, and this segmentation is facilitated by presence of disc. Now the disc sees to it that the shock that is imparted while we are jumping, running, etc., it is absorbed. So it is a shock absorber, as well as it is a ball bearing. If you bend forward, the disc slightly shifts back, the central portion. If you bend this side, the disc shifts on the opposite side.
Okay.
So it balances. It's
Okay.
a ball bearing also, it's shock absorber also, and it also allows movement.
Movements.
Otherwise, it will become just one stiff
Yeah.
unit.
Yes.
Also, human beings are amongst very few animals who can walk erect.
Acha.
And that is why the transfer of weight is very crucial through the disc. So disc observes all these, complex functions.
Okay.
Now, in slip disc, what happens is that the central portion, which is nucleus pulposus, jelly-like, it tears through the surrounding boundary
Oh.
of the annulus fibrosus
Okay.
and comes out. It is called a slip disc
That's
or
what is slip
herniate,
disc.
yeah,
Okay.
or herniated disc, slip disc,
Acha.
etc.
Uh-huh.
So when this happens,
Uh-huh.
usually it happens on the backside where the nerves are there. So in lumbar, I'm talking about the lower portion of the spine.
Yes.
And when it happens on the backside, there are nerves going to the legs.
Acha.
So if a large portion of the disc comes out, slips out, and presses on the nerves, then people get back pain, they get pain along the backside of the thigh
Acha.
and the calves, and it is commonly called as sciatica,
Acha.
right?
Acha.
So this is, in short or in simple words, what slip disc is.
Okay.
Next question that you asked was, how is it related to spondylosis?
Yes.
Now, see, spondylosis is the word which people use very commonly, but they
Yeah.
don't understand the meaning.
Yes.
In short, spondylosis means the aging process of the spine. Like if a
Okay.
person gets old, he will get a graying of hair, right?
Yes.
Similarly, the spine also ages. As it ages,
Mm-hmm.
the disc, intervertebral disc,
Mhm.
reduces in height
Mm-hmm.
because it becomes old. The
Correct.
water content reduces.
Acha.
As the height reduces,
Mm-hmm.
the body realizes that there is something wrong uh, in the equilibrium.
Mm-hmm.
So body's way of stabilizing any disequilibrium,
Mm-hmm.
is to send calcium.
Okay.
So body sends lot of calcium there.
Okay.
Calcium gets deposited.
Mm-hmm.
So you get stiffness there. You get sometimes calcium depositing and pressing on the nerves, what we call as osteophytes. So you can get pain along the nerves. So all this process, which is in essence actually aging of the spine, it is called as spondylosis. So it
Okay.
happens in everyone to different degrees.
Okay.
It may not progress to clinically relevant problem in everyone.
Okay.
But spondylosis
It's an age
happens,
related.
it's an age-related problem.
Age-related
Yeah,
problem.
correct.
So, sir, what are the common diagnostics or advanced diagnostic procedures that have come up when it comes to slip disc?
So you see, spondylosis of the lumbar spine
Mm-hmm.
or slip disc, when they come to us, the symptoms which are very common are, as I said, sciatica, that is pain
Yes.
along in the buttock, which spreads to the back of the thigh and
To
in
the
the calf.
lower legs.
Yeah, very severe
Yes.
pain while walking or
Yes.
climbing stairs,
Even
etc.
standing
Standing also
also.
becomes
Yeah.
difficult. If
Yeah.
it progresses to spondylosis and
Acha.
the entire group of the nerves which are going to the leg, they get compressed over the period of time, then we get what is called as neurogenic claudication. And
Okay.
neurogenic claudication means if a person starts walking, for first few steps there won't be any symptoms.
Okay.
After few steps, let's say about 5 minutes or 10 minutes, the person will start getting heaviness in the lower limbs.
Okay.
Sometimes there is tingling, sometimes there is pain. Also there is pain in the low back. And after some time, the person has to just stop or
Okay.
sit down and
Okay.
take rest. Otherwise, he cannot go ahead.
Okay.
And this is called as neurogenic claudication. After resting for some time, again he can walk for some more time. So this happens in slip disc and related spondylotic process on chronic basis.
Okay.
In acute phases, they come with severe pain or sciatica. If the disc is just protruding out, but it has not yet broken out, it is just trying to come out, then people get low back pain and no leg pain. So when such people come to us, the diagnostic modality that gives information is MRI.
Okay.
Because MRI shows the internal structure of the spinal canal, it shows the nerves, it shows the internal structure of the disc. However, CT scan has got ability to show bones better.
Okay.
So there are some cases wherein we want both MRI and CT scan to get enough information.
Okay.
And in some cases, we also need X-ray additionally,
Okay.
because you can perform X-rays in dynamic positions. Like you can ask a person to bend down and do the X-ray to see whether the bones are moving.
Yes.
So sometimes
Which
all
is not
these
possible
three,
in CT
yeah.
MRI.
So all these three, sometimes all the three modalities are required.
Okay.
But MRI has been game changer because it shows the internal structures. Only thing is people have to remember that MRI can be done in different ways. And there are different capacity machines of MRI and different sections can be taken. So MRI has to be ordered properly, done properly and read properly.
Okay.
In correlation with the symptoms. It is very important and that people have to remember.
So when it comes to the treatment options for slip discs, sir, how do you see, the technology has evolved over the last decade in the treatment of slip disc?
It has evolved by leaps and bounds.
Oh.
And especially during last 15 years to 20 years, we have seen a lot of technological advancements in this. However, when person suffers from slip disc, initially we treat them conservatively. We
Yeah.
don't advise surgery
Yeah.
because some of these discs which
Mhm.
have come out acutely,
Hmm.
some of these discs can get shriveled up with time,
Wow.
maybe 1 week or 2 weeks, and the pain can go away.
So this is typically when the bed rest or something like that.
Yeah, rest is now, it is a bit of controversial subject,
Okay.
but bed rest for 1 or 2 days, not more than that.
Acha.
But activities without lifting weights,
Okay.
lifting of weights is prohibited, but normal activities allowed.
Okay.
So something like that. Weight, give over the counter painkillers and
Medications.
anti-inflammatory medicines, and some of the pain, some of the disc pain, in some people, I mean, it can be treated.
Okay.
But if it continues after that,
Okay.
just to avoid surgery, trying to bear pain or trying to do some things which are not proven scientifically is not
Yeah.
right.
Like oil massage and all that stuff.
Initially,
people
massage
try
can
to-
be useful.
Okay.
I'm not saying,
but not on the long run.
no, I'm not talking about any particular modality. All
Okay.
modalities have their place,
Mhm.
but the thing is, one should not stretch it too much,
Okay.
because longer the disc is pressing on the nerve,
Hmm.
more is the chance that the disc has ability to destroy that nerve,
Oh.
and you have to bear pain.
Okay.
So it has to be a judicious decision by the
Hmm.
doctor and the patient both.
Okay.
And
Whether to
this
go
is
for it.
where a minimally invasive procedures
Hmm.
like endoscopy, microscopy come into picture.
Mm-hmm.
Uh, in olden times, the discs were removed with very long and large incisions.
Open
Now
back
it got
surgeries.
converted about 30-40 years back into microscopic surgeries.
Acha.
The microscopes also advanced with
Hmm.
time,
Mhm.
so the surgeries became safe,
Mhm.
they became very effective,
Mhm.
and they gave instant pain relief.
Okay.
And now we have endoscopes which
Okay.
can go right up to the place where the disc has broken out,
Mhm.
and we can just remove the portion of the disc
Hmm.
that has slipped out
Okay.
and keep the remaining part of the disc intact,
Okay.
so that this part keeps on giving support to the body.
Okay. So
Okay,
it's actually
so
a
function.
tiny camera which goes inside.
So the tiny system of lenses, the camera
Acha.
is outside.
Okay.
The tiny system of lenses that goes inside.
Acha.
It is of the diameter of let's say a fountain pen,
Okay.
and it goes to the place where the disc has torn its
Oh.
confines and it has come out. We
Okay.
go there and just pick up the fragment which is pressing on the nerve and causing pain.
Hmm.
So remaining disc is preserved. This is one of the advantages of endoscopy. And of course, the approach is very small. Sometimes we don't have to take a stitch, so it is called a stitchless surgery.
Hmm.
So endoscopy has its own advantages, microscopy has its own advantages. Sometimes if the slip disc
Mhm.
is associated
Mhm.
with vertebral problem, like slipping of the vertebral body,
Okay.
then you cannot rely on endoscopy or microscopy. Then
Okay.
you have to fix the spine. Otherwise, the pain will increase
Hmm.
because the instability will increase.
Mhm.
So what I mean to say is that every case of slip disc and
Hmm.
every case of sciatica,
Hmm.
every case of lumbar spondylosis,
Mhm.
of neurogenic claudication
Hmm.
is different.
Hmm.
You have to study it clinically, you have to
Hmm.
study it through MRI, CT
Hmm.
scan,
Hmm.
if required through dynamic x-rays,
Hmm.
and come to the conclusion
Hmm.
as to what treatment this particular case needs.
Hmm.
You have to come to the conclusion
Yes.
what definite treatment this particular case needs.
Correct.
Otherwise, if you use wrong treatment for wrong indication,
Hmm.
okay, the results will not be good. And it is very important to remember this,
Mhm.
because sometimes people get very funny ideas in their mind,
Hmm.
and they come to us and say, no, you operate us by endoscope only.
Yeah.
It is not possible always.
Yes.
It is like having different types of rockets with you in a war, but the size of the rocket and type of the rocket depends on where you want to attack.
Exactly.
So if you want to attack 1500 kilometers target, you cannot use a small rocket.
Smaller.
Similarly, if you want to do something very near to you,
Hmm.
you should not use a big rocket. So the armamentarium that you use
Mhm.
in surgery has to be as required by that particular, then only you will get good result. And people should understand this point very clearly and not be behind, asking for different modalities of treatment or different words like laser and such sort of fancy things that they hear on internet and Google and some marketing campaigns. They should insist that our problem should be solved. How is the lookout of the surgeon who is expert in that?
So basically, we can say that it is not that one size fit all.
Correct.
So on the same grounds, we can say that endoscopic spine surgeries is not a solution for all spine problems.
Certainly, it is not solution for all the problems, but where it could be a solution, it is a very superior solution.
Okay.
And the person who can do endoscopy, who can do microscopy, who can do open surgery, who can do complex fixations, who can do everything, has to choose between these.
And the right person to do that would be your surgeon, not you or Google or anybody else.
Certainly not. One who is very experienced in such surgeries should make the decision, and one who is able to do all the modalities.
Correct.
He should be able to do all the modalities, but still choose one that is correct.
That is the right person to do it. So how does this endoscopic spine surgery eventually improves the quality of life, and how is it different from the traditional open back surgeries?
See, endoscopy has changed the paradigm in one very important way.
Okay.
Initially, what used to happen was that, in the olden days, what used to happen was when one would get slip disc, he would wait for a long time, suffering pain, and then hope that the disc will go away, 3 months, 4 months, 5 months. All along this time he is suffering. He is not able to go to work properly, or he is tolerating pain, or he is taking painkillers. The painkillers are, causing problem to his kidneys.
Yes.
So these cycles are going on. So it's a circle, right?
Yeah.
So now he can choose if it is his problem is amenable to endoscopy or microscopy even. The microscopy is also minimally invasive procedure.
Yes.
So if it is amenable and the pain doesn't go with conservative treatment in, let's say, a week or two, he can get pain relief through these procedures and continue with his normal life.
Okay.
Now, endoscopy, some types of endoscopies we do under local anesthesia. We don't give general anesthesia.
Okay.
So it is called as ambulatory surgery. That means a person comes in the morning, we do the discectomy, we remove the portion of the disc that is causing the problem.
Yes.
And the person can be discharged in 3 to 4 hours.
So basically the patient walks on the same day?
Walks on the same day, he goes home and he can join work on the next day.
Oh, great.
So this is called as ambulatory surgery. Ambulatory surgery.
Wow.
But again, it has to fit your MRI and your problem.
You just can't go and demand.
Demand it. So demanding a procedure can land you in a soup. That's the message I want to give to everyone.
Yes. Let your doctor decide that.
You have to demand relief from pain.
Yes.
Demanding a procedure is a wrong thing to do.
So as you said, pain, right? So we have always heard that it's a no pain procedure, it's a painless procedure. So do we actually need to take any form of painkillers post the treatment, or is it actually that no pain?
See, if endoscopy can be used as a method, obviously the approach is very small. So the dissection is less. So yes, painkillers are required for some time, maybe 3 or 4 days, but for a shorter period of time.
Okay. Are there any downside or risks associated with this? Do people need
associated with
the endoscopic spine surgeries?
See, the risk is, as I told you, in my mind, the greatest risk is when endoscopy is done in, unindicated patient or the patient who is not suitable for endoscopy.
Achha. As you said before.
Yeah, so that is a risk, just to appease the patient's demand. Someone is doing endoscopy where it is going to be difficult to relieve the pressure on the nerve, then that is a risk to my mind. As it is, when we do endoscopy, we tell people that there is 1 to 2% failure rate, and then we may need open surgery because endoscopy provides very specific and limited view. Okay. So endoscope, that is a downside of endoscopy.
Okay.
Microscopy or slightly more open surgery gives you a better view, more wide
Visibility.
view,
Yeah.
and it gives more definite solution.
Mm-hmm.
But we always tell people that, see, you have to choose, because endoscopy is possible in your case, but 1%, 2% chance that we may need to do, open surgery if it
As
fails.
well. Yeah.
98% of the times you will not need it. So this, if you want to call it downside, it is a downside.
Mm-hmm.
If you choose properly, you can avoid that.
Okay. So, I'm very sure that you see a lot of patients who come to you who require endoscopic spine surgery, and many of them might be hearing it for the first time. So, what would be a few things that you would want all your patients to know about endoscopic spine surgery?
Yeah, apart, when patient needs endoscopic spine surgery, we explain the procedure to him or her in detail. Uh, we offer the choice of general anesthesia or local anesthesia,
Okay.
and this is a choice that he or she has to make.
Mm-hmm.
And then we tell them that the important thing that they have to follow after such surgery
Mm-hmm.
is early mobilization and early joining to the work, because it is important.
Okay.
Because mobilization and doing your routine work, it has been found that it helps faster recovery from spine surgery. In fact, we tell this to almost everyone who undergoes spine surgery, unless there are few cases where you have to tell them to take a rest for a long time. These are different cases, and these are more serious cases like tumors. So we are not talking about that, but we tell them to be prepared for this. Also, be prepared that there could be 1% chance that you may need open surgery,
Open surgery.
uh,
Yes.
at a later date.
Mm-hmm.
So all these things we first explain,
You explain it to the
and
patients.
then only we perform the endoscopy.
So, sir, before we sign off for today, my last question to you would be, what are the other advancements in spine surgery apart from the endoscopic spine surgery?
Oh, last 20 years have seen massive advancements in
Okay.
spine surgery. One, as we discuss, is
Endoscopic.
endoscope,
Yeah.
high quality and high end neuromicroscopes, which can
Okay.
look deep inside the spinal structures. We use them to remove difficult tumors of spinal cord. Then there are different materials now available to fix the spine, like titanium,
Uh-huh.
which is very lightweight but has got excellent strength.
Mm-hmm.
Then there are fusion materials, which are used to fuse the segments which are uh, more mobile than required. Intraoperative computer guidance
Mm.
and O-arm guidance
Mm-hmm.
has come up in a big way in last 5 to 10 years. So it's a very exciting time for the doctors and patients alike, because the results have become better, and we are happy because we are able to give pain relief and good life and good quality of life to the patients, uh, with a very minimal hospital stay.
Achha.
Also, there have been advancements in diagnostic modalities,
Okay.
like the quality of MRI to diagnose
Yeah.
the specific spine problem. So it's a lot of advancements, in short.
That's wonderful thing to hear from you, sir. And I'm very sure this podcast would have, enlightened a lot of people to understand how to choose their treatment options wisely. And it's always better to talk to your surgeon and not make a self decision on that. So, on that note, winding up today's podcast by thanking Sir once again. Thank you, sir, so much for coming back on the podcast. And I'm very sure many questions would have been addressed today. So, wait until the next podcast. Thank you.